So my session is skin tears. I am Simon Barrett, as Sam just said. I'm the TVN for Humber, not actually Hull. I used to be Hull and East Riding, but I now do Humber, so it's local to here, obviously, so you'll be familiar with the area from Hull up to Whitby. That is my area or patch. I also cover the mental health units in Hull as well, which I've got to say I find really interesting, trying to get that relationship with those patients. It's totally different to our standard patients, if you like. So hopefully you'll get something from this session. I'll try and be as quick as I can so Big Chris don't come back in and sort me out, because he's a lot bigger than me, as you can see, and hopefully you'll get something from it. Will you learn anything from it, do you think? Do you? Hopefully you might, but I don't actually think you will. I think all of these sessions today, it'll just be a reflection on what you already know, and it'll just reaffirm. And that's all I want from you really, is to make sure that we think about how we practice. Some of the things we do, we might need to think outside of the box and try and find the solutions. And what I will say to you, and I'll say to you very quickly now, and I may say it again because I'm doing a session this afternoon as well, you already know the answers without having to ask me, the TVN. Can I just ask, is there any TVNs in here? One TVN? Two TVNs. So there's two TVNs in here. Are you, the rest of you, community nurses? Just put your hands up if you're community nurses. If you're an acute nurse, put your hand up. Those of you that haven't put your hand up, have you got rigor mortis, or are you students? Right, there's two TVNs in here. There's a lot of other disciplines as well, I can probably assume. What's the difference between the TVN, i.e. me and the two ladies sat there, and yourselves that are not TVNs, do you think, when it comes to wound care? I don't mean anything else. What do you think makes us able to come up with a solution quicker, or more effectively, should I say, maybe than yourselves? You might argue that you don't. It's what? Experience and?
Knowing the products.
Knowing the products, right. It's interesting that, because people always say, tell me about the product. Tell me about the product. Right, so that's interesting. I'm going to flip that in a minute. Right, so experience and product knowledge. Anything else?
Focused on one area.
Are they? Well, it's interesting that, because my wife, she's a health visitor, and she said to me, Simon, when I start as a TVN, do not get focused on tissue viability. You've got to remember the holistic patient. So maybe, but I'll say, no, I'm still holistic, very much holistic. Anything else? There's one thing, something that I'll be in trouble if I don't finish on time. Time. I think it's time. I think it's time at the beginning. We're no better than you. This is what you've got to remember. I have not got any, miracle powers. Right, think of Dorothy, the Wizard of Oz, Yellow Brick Road. Yeah? Dorothy went to Oz because she got a knock on the head, didn't she? She was in a dream. I hate to spoil that for your Christmas coming up. But she was in a dream. She's laid on the bed, she wakes up and she's in Oz. Wow, flipping heck. And then she finds this yellow brick road. The good witch says, you've got to go to find the great Wizard of Oz. Follow the yellow brick road. So off she goes. Along the way, do you remember she finds a tin man, a straw man, a cowardly lion, all that are lacking something, right? They're not lacking anything really, it turns out, because when they get to the great Wizard of Oz, do you remember, it's this little guy behind a curtain turning a wheel. Toto the dog goes behind and finds this bloke going, I am the great Wizard of Oz. So you're thinking to yourself, what's wrong with this bloke from Hull now, aren't you? What I'm trying to say to you is this. All those characters, the straw man, the tin man, the cowardly lion, etc., and Dorothy actually knew the solution to getting home before they found the great Wizard of Oz. So the great Wizard of Oz potentially is me and the TVNs. We're turning a big wheel, creating lots of steam. But in actual fact, you lot already know the answers. All you need from us is just a little bit of confirmation to give yourself that confidence to make that decision. So the difference going back is, if I invest time at the beginning, whether it's looking at skin tears, pressure ulcers, leg ulcers, leg edema, whatever it is, if I invest some more time at the beginning and give myself that confidence to spend that time, there's a fairly good chance I will end up with a good diagnosis, a good treatment plan, and therefore hopefully quicker, better outcomes. That's all it is. And the key to that door, if you like, is always going to be the relationship that you have with your patient. You've got to have that relationship at the beginning. So if I'm a nosy parker, now I don't know about yourselves. In Hull, we used to have a place called Prospect Centre when I was a little lad, or in my teenage years. I used to go and sit and people watch just to see how people interacted. And it's the same sort of thing now. We're working in that same interaction, watching how people communicate and how we communicate back. And I was doing some online training yesterday. Can you believe? Here you go, mandatory training. I had a spare half an hour. I thought, can I fit conflict resolution into half an hour yesterday? And it said 40 minutes, and I was off. I was off like the clappers, because we have on a Tuesday our press rules to review and learning panel. So I had to get ready for that anyway. But I had an half an hour slot after seeing the patient. I thought I'll try and do it. And it was quite interesting reflecting on conflict resolution when you spend that time and get that relationship with the patient. So, skin tears, let's get back to it. Oh, that's me. Right, so who's at risk? Who's at risk of skin tears, age-related changes, extrinsic factors? The International Skin Tear Advisory Panel. That, I don't know, it's a bit of a tongue twister, is that one? But the International Skin Tear Advisory Panel, so that's where this presentation comes from effectively. Assessment and management, inappropriate dressings, which comes back to what you were saying, knowledge of dressings. Silicone dressings for skin tears. Now, silicone dressings have been around quite a long while, haven't they now? And I do remember going back to the days, if anybody remembers it, of Heal Not Hurt, which was set up by Monica about 15, 20 years ago now, because they brought out the first silicone dressings and complications associated with skin tears. So, what is it? Well, it's a traumatic wound caused by mechanical forces, including removal of adhesives. Now then, hopefully we're not using those old-fashioned strong adhesives. Hopefully we're not, but it'll be interesting to find out what dressings we are using, which I am going to ask you later on. So I'll try and fit it into these presentations as best as I can. So hopefully we're using silicone. If we are using stronger adhesives or old-fashioned technology, hopefully we're using it on good, healthy skin that's not going to be traumatised. Those population, or that population of people 65 or over, become a little bit more fragile, a little bit more at risk, as much as 40% more at risk. So probably all those patients on 65 or over, and I'm not just saying we're not looking at these patients individually, but the risk for them having less tensile strength in their skin is 40%. That's also the same for neonates, if anybody's working with neonates. So we've got to take extra precaution with those categories of patients. So we've already mentioned the elderly, 65 neonates, 40% higher risk. So please make sure that we use appropriate silicone dressings for adhesion where we possibly can with these patients. Now, sometimes people say, hey, but these dressings are more expensive than traditional old therapies. Trust me, in the great shape of things, if you're paying £1 more for a silicone dressing than you would be for an old traditional therapy, it may add up over time, but I'll tell you what, if you start skin stripping, you will end up with a wound that becomes more and more chronic, a patient that comes non-concordant, a patient that ends up with a chronic wound, and it takes more contact time from yourself. The dressings and the inexpensive part, they might be £3 to £6, but in actual fact, your contact, if you go out to do a visit at band 5 or 6, it's going to cost at least £65 for your visit time. So the dressing is the inexpensive part. And I would also say this, the dressing is also the icing on the cake. It's your assessment that creates the ingredient, shall we say, and the dressing is just the icing and the appropriate bit that goes on top. So that takes me back a little bit to what you were saying with regards about dressing knowledge. It's more about the assessment knowledge and putting the appropriate dressing on at the right time for the right length of time, and making sure we're not using sandwiches, etc., etc. If you're familiar with sandwich dressings, by that I mean, oh crikey, I still see it going on, to be honest, even in my own trust, but sandwich dressing could be a hydrofibre followed by a foam dressing, followed by a super absorbent, followed by, just because it's in the dressing pack, a piece of gauze, and so then all of a sudden you have a sandwich dressing. And that then starts to get me worried when the lady was talking about compression, because if you put compression over a sandwich dressing, it's going to alter the compression that's applied over that limb. So the circumference of that limb as well needs to be remeasured. So just bear it in mind, and it also makes it very difficult to keep the dressings in place. So young skin versus aging skin. Well, as you can see from the diagram in front of you, there's changes already with the fatty globules are changing, the epidermis is narrowing off as we're getting older, and everything becomes less resilient and it becomes more movable. I hate to say this, but my aging skin, having done nursing and tissue viability now for, this is my 38th year, which I know you're thinking to yourselves, God, he doesn't look that old. I started when I was 9, I must reassure you. But I don't know whether you've ever looked at your own hands when you're driving, have you? So when you're clinging on, because a lot of women, they just cling on and hope for the best, don't they, when they get, don't they? It's right reverse parking, isn't it? How many women in this room can't reverse park? My missus is one. Bloody hell. She's like this, you know, doesn't use a mirror. She's like this, so you get a bad neck, you will. But anyway, now I've insulted you all and pricked your attention up. So you're driving along, and once you relax your hand, look at your hand how it changes. So my hand, when it's flexed tight, is really quite nice, but then when it's flexed back, the skin starts to move and it starts to wrinkle. And I do go back to the time, I don't know if anybody remembers, it was going back about 15 years ago when the product was very big. Promogran, do you remember Promogran, protease modulating matrix? Now that was based very much so on collagen. Now I would ask you the question, have I looked after my skin as well as I should have done, remembering that I am only 46 years of age. Have I looked after my skin as well as I should have?
No.
Pardon?
No.
Outside now. Right. So this lady quite categorically says, no, I haven't looked after my skin. And so does my wife. So the reason she says it, she said, you look like you've got a decapitation line across your head. So I've got this decapitation line across my head. Now, the simplest solution would have been to have grown a fringe, but unfortunately, it keeps slipping back, so that's not happening. Now, going back, I don't know whether I should admit this, I thought, I've got this collagen product, I'm going to moisten it and put it on and just see what happens. Not a thing. Not a thing. Now, as you've correctly identified, I've not looked after it as well as I should have done. So what should I have done? I should have moisturised and hydrated my skin better, shouldn't I? Do we do that enough then, do you think, for our patients? Do we clean with a pH neutral soap and then do we use a moisturiser as we should? I don't think we do. And I certainly don't think if we do blather people up with emollients, I sometimes worry that we then don't clean them off appropriately. So please look after your patient's skin, maintain it, and don't end up with the decapitation line that I've ended up with, unfortunately. So the epidermis is the outer layer of the skin, and it does flatten and it does make it more susceptible, and like I say, you get that movement. We've lost the collagen, we've lost a lot of the fatty tissue, so we've got that movement, so it makes it a little bit more susceptible to skin tears as well. So please bear that in mind. I went round to see my dad on, what day was it? Oh crikey, Sunday. So I went to see my dad. My dad's 80 years of age. He obviously had me late on in life, didn't he? Because I'm only 46, remember. So he sat there in his Shackleton's RC chair. Now, I don't know if you remember them, Thor Head on a Sunday afternoon. Oh, get your Shackleton's RC chair. This is the best thing you can do. Well, it isn't the best thing you can do, is it? Because my dad, he was struggling with his back. So he'd got himself this Shackleton's RC chair, which I'd said, don't get one of them. But he did. He got one. And there he is, sat at the age of 80. He looks good. His back's comfortable. So what's up with your legs? Well, he's got this edema now in his legs, isn't he? Because he's sat there with his legs dependently down with the restriction behind the knees at the popliteals and in his iliac, so he's getting no return. And he sat there like that, and I said, what you got that tubey grip on your leg for? So he said, oh, it just holds the dressing in place. I said, what you got a dressing on for? Because he's got this fluid that's built up in his leg. I said, I asked you to get a recliner so you can get your legs up and elevate, do your ankle exercises, plantar flexion, dorsiflexion. But nope, so he's got these skin breaks now, little skin tears on his leg and little blistering. So even a TVN can't inform his own dad. So we've said dermis becomes 20% thinner with age and makes the patient 40% more susceptible, certainly that 65 and over. Blood vessels become more fragile, the microcirculation to your skin becomes impaired, which puts us at risk of skin damage, pressure ulcers, and that's why we've got to take that extra special care. Collagen levels are depleting. I'm not suggesting you all go out and have collagen implants or anything like that, although I must admit my wife always used to say to me, why don't you get something done with that? And I think, you cheeky beggar. So I was at one of these events, and it was one of the TVNs. She had an aesthetic company, and I said to her, hey, can you do some Botox on that? So she said, oh, it's beyond Botox, you need fillers in there. So I said, oh, I'll live with it. It's, you know, at my age now, 46, it's my time is done. So also subcutaneous fat layer thins with age. Well, if that's the case, I don't know what's going wrong with me. But we were just talking about it upstairs. I've actually put 2 stone on, so obviously because I'm in that intermediate age group, I ain't got to the subcutaneous fatty layer that's thinning just yet. But unfortunately, I'll give you this as a takeaway little message, because we all want to be happy for Christmas, don't we? Our hips automatically expand by 1.5 centimetres, whether you're a man or a woman. Don't matter, it's not to do with childbirth, that's a different matter, and you'll expand because of that as well. But your hips automatically expand by 1.5 centimetres. If that's the case, it puts your ability to retain your stomach muscles in the same format that they were when they were young, in a completely different situation. My lad, he's only 16 years of age, and he said to me, look at this, Dad. So he took his top off and went like that and flexed himself, and he was ripped at 16. And I said, look at this then. So mine was a beer barrel. So unfortunately, there's not an awful lot we can do about it, is what we're saying. But remember, because of fatty tissue, and it's the same as the elderly population, if you do have that extra bit of fat and you're having abdominal surgery, it's very hard for the microcirculation to penetrate through that fatty tissue. So try, he says as he breathes in, try to maintain an appropriate weight. It's like, guess the weight. If you was guessing my weight, how much would you say I weighed? Just be careful. How much?
65.
What, pounds?
No.
Kilos? What does that equate to in stones?
No, 70.
77 kilos. I can only do it in stones. I'm that age. Just remember, I'm 46. We didn't do kilos then. I was last week, 15 stone, 2 pounds.
Should we convert it?
So, in other words, it was fat. So, try and maintain your perfect weight. It turns out mine was statin injury. No, I'm not.
You're not. 95 kilos now.
95 kilos. Is that what 15 stone 2 is?
95.25.
That is, no.
No.
No. You don't want.
Oh, thank you. See, from the insult to I don't look it, you see. I knew I could turn it round.
You are wearing.
What am I wearing? Don't be so rude.
When you weigh yourself.
I've got them pulling pants on. I remember once going out with a girl.
What in the pocket?
What's in the pockets? No, I was in the NIF. I was in the NIF. So anyway, yeah. What was you wearing? Oh dear. Right. So risk factors. So the things we've got to consider is: are we taking in the right nutrients? Are we taking in the right hydration? So thinking about that. If you put the wrong fuel in a car, and I don't know if anybody's done that before, but petrol into a diesel, then it will get you about half a mile down the road, and all of a sudden it goes chuk, 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 and conks out. So it's not a good thing to do, because it means you've got to then have a mechanic involved who's got to strip parts out, and it's got to be all drained out, and it's quite expensive. Well, it's exactly the same with your diet. If you put the wrong things in, i.e. if we've got people with leaking wounds, whether it's lacerations, leg ulcers, whatever, that are leaking high volumes of exudate with low viscosity, then the protein leaking out needs to be replaced to get the healing to occur. So please consider how much fluid is coming out of this patient, how much needs to go back in. Do I need to put protein supplements in? Have they got access to the right nutrients to enable them to be able to heal? History of skin tears. Again, whether it's skin tears or any types of wounds, your skin has a tensile strength of about 70% after healing. So wherever the wound is, whatever the wound is, whether it's a leg ulcer, a pressure ulcer, a skin tear, whatever, you've got a maximum of 70% tensile strength. So that means you are going to be at risk of breaking down if you do not protect again. Drugs and medication that may cause, it says, disorientation and skin thinning are, give me an example. Steroids is probably the most obvious one. What might be something that induces ulceration of the skin? Can you name that one? Do you want me to give you a clue?
Yeah.
It helps that. Nicorandil, somebody said it, didn't they? I heard them say. Yeah, it's Nicorandil. Be very, very wary of Nicorandil. It's a cardiac drug. It's an old timer, if you like, from a point of view, but be very wary. Nicorandil does induce ulceration right near your anus. Now, if people say to you, oh, I've got this circular ulceration right near your anus, it's highly unlikely to be a pressure ulcer because you've got your buttocks that support you. But if you get a circular ulceration right near your anus, it could be Nicorandil induced. So always be wary, always check your medication. There's also evidence to suggest it induces leg ulceration as well, so just be wary of Nicorandil. Immobility causes susceptibility to the skin. So again, it's not just your immobility with regards to, it's how you walk. So if I'm walking and I'm doing the alley shuffle, if you like, my ability to trip, slip or fall over something like that, you put your hand out, you break, you fall. And I've been through that circumstance, unfortunately, on a cycling accident. You put your hand out, the next thing, you fracture your clavicle as well. But at the same time, you lacerate your hands, because that's the first point of contact. And having done that, myself falling off a cycle, I lacerated my hand, lacerated my arm, and I lacerated a big V in my back. Now, I remember them in York. I'd only got as far as Malton. I was doing 100 miles a day. I only got as far as Malton, so it was a good get out of jail card. But in actual fact, I ended up in Rhesus. They thought I'd broke my neck. Now, when they sorted me all out and everything, they said, oh, you've got this big laceration on your back and you've got these lacerations on your hand and your arm as you tried to break your fall. They said, don't worry, we'll go and get you some dressings. I said, oh, aye, will you? So he said, yeah, we'll get you these real nice dressings. They came back with... No, I was beyond steri-stripping. It was a massive V in my back. I looked like that advert for sure, you know, the big tick. A pad?
A continence pad.
No, not a continence pad. I hadn't lost my bladder. No, they came back with a big sheet of Gelinette. So I said, I'm really sorry, but that is not going on my back. So they said, what do you mean it's not going on your back? So I said, because the warp and the weft, i.e. the way it's knitted, will allow for granulation to go through. It will stick to my back, and when it then needs to come off, I will be in agony. So they said, oh, and what's your experience then? So I said, I'm the TVN for the Next Door Trust. So they said, oh, we'll go and get you something. Came back. What did they come back with? Bit of Bactigras. I said, no chance, that's not going on neither. So they said, what do you want? I said, I want a silicone-based dressing, please, or a lipocolloid if you could. So they said, came back to me. I said, really sorry, we haven't got any of that in stock. I said, don't worry, I've rang my wife in the meantime. She's on her way from Humber. She had, at this point, I was in Rhesus, new Volkswagen Golf, reversed it into a brick wall. Very expensive accident that was for me. Also consider your comorbidities. So what are the chronic disease? If patients suffering with dementia have they got the same visual context, are they going to be at risk of slip, trips and falls? Again, I'll use the example very quickly of my poor gran. She's been dead for 15 years now, but I remember her being discharged into this care home, which I didn't actually know about at the time. I went round on the first night, I'm not kidding you, there was cables hanging from the ceiling across the floor, and they said to me, oh, it's going through a renovation. I said, you can't have people expected to walk about like this. She's got vascular dementia, she's going to have trips, slips, falls, lacerations, etc. So they said, what do you want me to do? I said, I want you to get me the owner of this place. Oh, he's abroad on holiday. So I said, fantastic. I said, well, get hold of him, because she's not staying in here another night. Well, not staying in here tonight. So please be wary for that if you can. Smoking, again, why does smoking affect it? Well, as it says, it accelerates the aging process, but it's that microcirculation, because it caused the hardening and the narrowing, and your artery's ability to carry the blood to the peripheries is restricted or reduced, then it causes the aging process. Good job I didn't smoke, isn't it, with these lines, otherwise I'd have been in deep doo-doo. So again, please bear it in mind when you're trying to look at that holistic picture. Try and remove the risk factors. So the risk factors are the friction. How many ladies, I won't say men, but how many ladies have gone out on a Friday night in the nice high heels? It's funny, everybody's real tall on a Friday night when they go out, aren't they? Friday night, they go out in the high heels, and then at the end of the night, oh, they're all back to my size. Well, where are you gone? So why is that? Because they've gone out in the new shoes, blisters on the back of the heels, blister D roofs, all of a sudden you're in agony, aren't you? So remember what that pain feels like, because a lot of these people with the skin tears are going through exactly the same sort of pain. Blunt trauma, we talked about slips, trips and falls. Try and remove the hazards depending on the environment that you're working in, whether it's community. How many times do you go into a patient's house in the community and they've been collectors? They've collected everything over the years, haven't they? There was this guy who used to live out near Goole, and he lived in these two joined caravans. Well, he used to knock on the outside, and then you had to crawl in through the newspapers that he'd collected of all his memorabilia. To get from his kitchen to his bedroom was a hole like that, and you had to climb through it. We offered to go around and remove all these dangerous belongings, shall we say, but he would not have it. He wanted to stay as he was. And he had capacity. And that's the thing, remember capacity assessments. Shear, so hopefully things have improved since my day. Well, they have, hopefully they have. Going back to my day when I used to work on the wards, which was, well, I've got to be careful what I say, aren't I, because I'll give my true age away. But in the 80s, shall we say, because remember I started when I was 9. So in the 80s, we used to do the Australian lift, do you remember it? It was like something like Bruce Forsyth. I'm not the same since. I was 6'2" and broke my legs because of that. So please, hopefully we've got equipment in place now that will reduce the risk of patients being dragged along the bed. I'm not suggesting the Australian lift did that. I'm suggesting the Australian lift nearly killed all nurses. But we've got equipment that can take away that risk to us, the risk to the patient now, repositioning pieces of equipment, etc., etc. So common locations of skin tears, upper body, trunk 48%, lower body, if you like, is 52%. Now again, I don't know about yourselves, and I don't know exactly where you work, but I work in the community now and mental health. I would suggest the most skin tears that I tend to see tend to be on their arms, if I'm honest. Yes, you do see a few on the legs where they've had that trip-slip accident as well and caught it on. I'll tell you what is really bad. You know, when coffee tables are at such a dangerous height, and that for elderly people, unless I suppose the Zimmer frame protects them, but if they're walking freely, them corner of blooming coffee tables, it's effectively the same as I did moving my daughter and my mate the other day with the tail lift. It was just at the height, right on my pre-tibial area. And I thought, before I get a hematoma and a skin tear here, these compressions going on. So be very, very careful. Be aware of where they're going to occur. Now, the international panel have said, look, there's a pathway in place. So skin tear risk assessment. And I believe we should probably do these sort of pathways for everything. Because if nothing else, it's an aid memoir. So you look at your patient wound environment, look at the risk categories. How is the skin? What's the mobility like? What's the general health like? Does that add up to a risk factor? The same as you would do a risk factor for your pressure ulcers. If it does, we come to an at-risk. Is the patient any identified risk? Yes or no? We implement a risk reduction program, the same as we would if it was a pressure ulcer. So all this investment that we keep talking about is about pressure ulcers, pressure ulcers, pressure ulcers. Let's get the pressure ulcer categories down. But we do within PEARL, this thing called PEARL, which is our pressure ulcer review and learning panel. Everything that comes through with a wound is Datex now. And what we're finding is we're starting to get filtered through now, skin tears, and it's coming actually from mental health at the moment. So it's really interesting that we're starting to look at skin tears maybe in the same way. I would suggest you look at the root cause. You know, so when you get a pressure ulcer, we investigate, we do initial incident reviews, we do SIs, we do IRs, we do whatever they're called in your organisation. But maybe we should just do in our head a root cause of why did this happen in the first place? What do I need to put in place to stop this from happening again and causing harm? Because it could become a chronic problem, it could result in sepsis, it could become life-threatening to a patient. So please, please, please bear it in mind. We've talked about hydration, skin care we mentioned right at the beginning. Always best to hydrate. Have we got any men in here? If you are a man, put your hand up. Now, gentlemen, how many of you practice good skincare? Or have you all got decapitation lines like me? Right, nobody's hand has gone up again. So I think there was about 5 or 6 men in this room and none of you use any skincare products, which is the lowest ever of this year's road shows, because most of them have used skincare products. So men, we've got something to learn, haven't we? Ladies, I'm going to ask you the question. How many ladies in this room, put your hands up, use skincare products to hydrate? I would say probably about 75% of you. So well done, ladies. You are the sensible ones. In a poll today, ladies are more sensible than men. Quote Simon Barrett, 2023. So yeah, you might not be able to reverse park, but you look after your skin better. So we've talked about nutrition, and that's for all wounds. I don't want you to just think about skin tears. Please get the right level of protein back in for the protein that's lost. We've talked about environment and we've mentioned about skin adhesives. Please make sure that you're not using old technology skin adhesives on skin tears or any fragile skin where there's a wound. Skin is what? An organ. It's the largest organ on the body, isn't it? Does multiple things. Do we look after it as well as we should? No. Probably not. Look at me. If I was to stand here, please God, don't let it happen. I'm only young, I'm 46, remember. If I was to have a heart attack now, you would all run forward, not all of you hopefully because I'd get stampeded, but you'd run forward and you'd resuscitate me, yeah, and you'd hopefully bring me back to life. I don't want the Vinnie Jones thump one, I want the full blown, job. So get me back to life and make me okay. If I was to trip over this cable here, you'd probably just go, you silly old devil. You'd go and see if you could whip some out of the dressings out of the next door, well, upstairs room, wouldn't you? Unless you've whipped some already and you've got them in your bag. And you'd put something on and they'd go, there type of thing. Silly devil, don't do it again. We don't value our skin in the same way that we do our other vital organs, is what I'm trying to say. So maybe we need to start to turn that cruise ship thought round. It'll be a slow process, but we need to make sure that we value our skin as much as we do our other vital organs. So the International Skin Tear Panel looked at classification. Now we have classification for pressure ulcers, don't we? We don't have classification for cavity wounds, but we do have classification for skin tear. We've got type 1, type 2, type 3. Depending on the severity or the type, then we may be able to look after and manage that wound ourselves, or we may have to refer on potentially to plastics. Now again, there's a little tip here. If you ever do sustain, or a patient of yours sustains some damage, a blunt trauma, and you start to get the beginnings of a hematoma, don't wait to put the compression on. Put a little bit of compression, about 8 millimeters of compression. So I'm talking a woolen 2 crepes. Give a gentle squeeze and it'll reduce the risk of that breaking down and then becoming a long-standing problem. Hence why I got my class 1s on very quickly as soon as I did my blunt trauma. So there's a pathway that we should follow, and again, the treatment plan will vary. So we should also consider, like I said, what's the root cause? Where's the location? Are there any signs of infection? Are we able to identify what the infection signs are? So is there a malodor? Is there an increase in pain? Is there an increase in exudate? Is there any inflammation? All the things that we start to put our jigsaw parts together. Look at the wound size. Do I need to take further advice from the TVN? Is there a pathway in place? Look at the exudate level. Is it serous? What is the viscosity like? Is it thick custard like? Is it indicating how much protein's coming out? If there's bleeding, I need to stop it, don't I? Usually 10 minutes will stop any bleed point unless it's an artery that's it's in the ceiling. We're in trouble then, but stop by pressure. Consider the peri-wound skin, vital to get any, if we've got tissue loss, we need a good peri-wound skin. I say to my lad who used to be a competitive swimmer, always look back down at the board that you're taking off from before you go off down there. He used to say, why Dad? Make sure, because you don't want any wet maceration. You don't want any wet at your foot, same as maceration, because all that'll happen, you'll dive in, you'll belly flop, your other colleagues will be down the pool. It's exactly the same with the skin. If we don't look after that surround, the epithelial tissue won't be able to swim across the granulation, it'll belly flop in. We've got a static wound. Feel and palpate, which we don't tend to do anymore, for warmth. Sniff, using the things we were given, like the Bisto kid. Is there any malodour? What does it indicate? I saw a woman the other day, a poor young lady had aerosol burned herself, and she had some Pseudomonas there. Well, that Pseudomonas smell we can all recognise, can't we? It's almost like that's part of hospitals in the old days. And pain, what is the pain like? Pain is a really good indicator for many things. Type of ulceration, if it was a lower limb wound. Just very quickly, I'm going to give you a quick question. If you get pain in your wound and it's lower limb, is it venous or is it arterial? I'll give you a clue. Venous, because you get the pain in it because it's superficial, nerve endings are exposed, and you get that fluid rush, so it's in the wound, so it's venous. If it's in your calf, it's calf pain, not the wound, it's arterial, because you're not getting the blood supply down there, so you're getting the cramp. So the management, like I say, another pathway: control the bleeding point, if any, cleanse the wound, remove any dead and devitalised tissue, if appropriate, and any foreign bodies that may have crept in there. And when we say cleanse and debride, that's a slight crossover word, isn't it? Because if I asked you in this room, how many people in this room do a debridement, you will put your hands up and say, who does a debridement in this room? 2, 3, 4, 5. 5 out of 100 people, so 5% do debridement. I would challenge you all, if you're all looking after wounds, and say that you're probably all debriding, because you are creating a warm environment that allows for autolytic debridement. So you're all promoting debridement. Or you could be cleansing stroke debriding. It's a dodgy one like that. So reapproximate the wound edges if you possibly can. Do not steri-strip. Dress the wound appropriately using a silicone-based contact layer, something that you don't have to keep removing. It is not appropriate to keep removing it to have a nosy, because we are nosy nurses, aren't we? I'm a little bit like that. I have to have a look, but no, I won't do it. So please put a dressing on, a primary dressing that you don't need to keep taking off. Now Richardson have got their dressing that they've put round and you've got in your hands. I can see it in your hands now. If you haven't already, when you leave the room, you might want to have a little fiddle with it and just see how comfortable it is to put on and take off. If you want more information on this product and how comfortable it is, how cost effective it is, and also their skin tear emergency kit boxes, then please go to their stand. What I would also say to you is this: when you go to Richardson's stand, you've got breaks that allow you sufficient time to get to all the stands. You've come on your time today, make the most of it, get around all the stands, make sure you get as much information from those company representatives, and make sure you take away as much learning as you possibly can. So monitor. Don't take a skin tear primary dressing down. How often should I look at it, really? I would say 5 to 7 days is the guidance. 5 to 7 days is your primary contact layer. Don't take it off. That's not to say if you've got leakage through onto your secondary, you change your secondary dressing. And please remember, document, document, document. If it's not documented, it's not done. So inappropriate dressings would be steri-strips. This is according to the International Skin Tear Panel, not me. This is their recommendation. Unless you've got a linear insult that you can realign, do not use steri-strips. Do not use them on fragile skin. They will strip. Do not use old style technologies in the form of adhesives. Iodine dressings or inodine dressings, if you're using it as an antimicrobial, where the wound is dry, eschar, it's okay. Where there's any moisture, it will deactivate the inodine within 2 to 6 hours. That means you would need to change that dressing between 12 and 4 times a day, which would not be appropriate, because the cost, remember, is you going in, out. Your £65 a visit, you can't maintain it. So choose dressings, if you need an antimicrobial, that will sustain their release. Also, I don't know whether you can see it, and I'm not knocking inodine because it's a very inexpensive product, but the warp and the weft allow for granulation, you know, like I said, with a gelinette to grow through, which will cause trauma. You'll get a non-concordant patient. But for certain wounds where it's dry and necrotic digits, etc., it's absolutely fine, cost effective. Don't use non-adherent gauze, again for the same thing, the warp and the weft. Foam dressings can be used, but again, please use silicone based where it's a skin tear and fragile skin. Again, the International Skin Tear Panel recommends silicone dressings. They're atraumatic, they're flexible, they're conformable. They will allow for fluid management because it'll go through onto the secondary dressing. We're okay to change the secondary dressing, just don't disturb the primary for 5 to 7 days, allow it to take effect. You want them to be low allergy dressings, and again, the only way sometimes you'll find that out is if the patient wears it, so just keep an eye on it. Saves nursing time, that's when it becomes cost effective. A dressing is only cost effective, like I said, it's the icing on the cake, if you do a good assessment at the end. We then become cost effective to our organisations, and our organisation says, oh, your budget's going down because we're putting products on and we're leaving them in situ for a sustained period of time. All right. So again, compliance is associated. We've talked about complex wounds. We talk about it in terms of time. 4 weeks for a complex wound, possibly. I would argue that it could be complex from day one. Infections, we've mentioned about the signs already and the symptoms. Pressure injuries could develop as a result of skin tears, so please prick your ears up to that. And obviously we've mentioned pain and suffering. Pain is what the patient says it is. Please document it as part of your documentation. So remember, assess, 1, the patient, 2, the risk, react, time limiting. If it's appropriate, get that non-adherent silicone-based dressing on and a little bit of compression if appropriate to lower limbs, and manage it safely and appropriately. So that completes this presentation. I will say thank you very much for coming, and I will see you this afternoon, unless you have any questions now. No. Was you doing a dance there, young lady, or was that part of a question coming up? She was just doing some skincare, wasn't you? Okay, so thank you very much then.